Hi, everybody. It's my pleasure to welcome everyone to tonight's webinar. My name is David Bonchat, and together with Jason Fisher, I serve as the co-chair for the RFS Communications Committee, the Society Interventional Radiology RFS section. Thank you for taking your time tonight to hear this webinar on advocacy and health policy. Before we begin our session, I want to remind everyone that this is recorded and will be available on YouTube by searching IR Education. Feel free to ask questions at any time. You can enter them box on your GoToWebinar control panel. We'll keep track of them and then answer them at the end of the webinar. Also, please check the RFS website regularly for upcoming events and follow us on Twitter, Facebook, Instagram, and Figure One for other updates and posting of clinical material. Without further ado, it's my pleasure to introduce Alex Kutsenko, who's the RFS Advocacy, and she'll introduce our speakers and give some more information about tonight's webinar.
Good evening and welcome to the IR Advocacy and Health Policy webinar organized by the RFS Advocacy, Health Policy and Economics Committee. We are incredibly honored to introduce extraordinary leaders and IR advocates, Dr. Benenati and Dr. Hawkins today. Dr. James Benenati is a medical director of the Peripheral Vascular Laboratory and Fellowship Program Director at the Miami Cardiac and Vascular Institute in Miami, Florida. He's a program director of ISET and CIO conferences and past chairman of the SIR annual meeting. He's a professor at Florida International University, Herbert Wertheim College of Medicine, and professor at the University of South Florida College of Medicine. Dr. Benenati served as the president of the Society of Interventional Radiology and received highest honor SIR Charles Daughter Award in 2014. We're incredibly honored to have his continued support for IR advocacy. Dr. Matt Hawkins is an associate professor at the Emory School of Medicine and a director of Pediatric, Vascular and Interventional Radiology at Children's Healthcare of Atlanta, as well as director of the Hawkins Healthcare Consulting. Dr. Hawkins is a chair of the SIR Coding and Reimbursement Subcommittee, SIR Alternate CPT Advisor, member of the ACR Board of Chancellor, and board director for the Society of Radiology Political Action Committee. We're exceptionally proud and happy to learn from Dr. Benenati and Dr. Hawkins today. Also with us on the call is Judy Bukalev, who is the SIR Director of Government Relations, who will be able for discussion and questions at the end of the webinar. We will start with Dr. Benenati discussing the importance of political advocacy in shaping interventional radiology within the changing healthcare environment. Thank you, Dr. Benenati.
Well, Alex, thank you. And to everyone out there, thank you for giving up some time this evening. And to Matt, thank you very much for being part of this. I definitely look forward to hearing what you have to say. So it's a real pleasure to be here. I've done a number of these webinars for SIR, and we talk about things like pulmonary embolism, PAD. But tonight, we're not really into a disease-specific issue. We're really into something that a lot of people in our society don't know much about and really don't get too involved with, but is really critical for not just our society, but for each of us in practice. The advocacy projects that go on within the society are vital to every one of us every day. It has to do with our billing and reimbursement, the way we're recognized as a specialty, and basically who we are as interventional radiologists. So I'm going to focus a little bit on some of the political things and also talk to you in some ways about why you may want to get involved in advocacy, why you may want to volunteer, and what you can offer. So let's see. Okay. So I don't have any disclosures related to this topic. And so the question is, what does advocacy really mean? You hear the term, what does it mean? You go to the annual meeting, you probably go into all the talks you're interested in, but what is advocacy? And this is really where our society is advocating on behalf of all the members not just of the society, but really of the interventional radiology community. And who we're advocating to, we're advocating before Congress, insurance carriers, and most of the key decision makers in healthcare. We also reach out around the world. So there's international advocacy. We work closely with our international colleagues at CERSA and the Asian Pacific Society. We advocate in private sectors to ensure that interventional radiology is understood and well represented. And we do this through really a wide range of communication channels. So why have advocacy? So, you know, this is kind of a cartoon or a schematic of what's going on in healthcare. And I don't think any of us could really navigate through this. And this is, you know, as healthcare becomes more complex, we need help in trying to figure out how to navigate and where to go and who will actually listen to us. You know, what channels do we have? So SIR has been awesome over the past really 20, 25 years in working through this huge maze that we call our government bureaucracy. And most people don't realize how active we are in advocacy in our own society. Another reason we advocate and we need advocacy is because we as a group of interventional radiologists, while we're very proud of what we do, and we should be, and we're a super competitive and highly well-trained specialty, the general public doesn't understand who we are. And in fact, this is from a publication in Canada, but Mark, who's a good friend of mine, did this survey, and it turns out that 94% of people aren't aware of what IR is, or even that we're doctors. Okay, and the ACR has done similar type surveys showing this. So if 6% of the people are aware of who we are, it's hard to get a lot of support in Congress and the House of Representatives for money, for codes, for what we want to do, if most people in the community don't care. So we advocate to all the agencies I mentioned, but we also need advocacy with the general public, so that they understand who we are and what our mission is. So the SIR as a society is focused on governmental policies that affect interventional radiologists and our ability to take care of patients. SIR does this by active lobbying, by active participation in relevant coalitions, and by public education initiatives. We also have grassroots advocacy that allows us to integrate our grassroots, our members, with these big advocacy projects. And we're going to talk a little bit about grassroots advocacy because that's where you all can get involved. There's things that you can do on a local level. So while the society is doing a lot through a number of different committees, we as individuals in practice also have to get involved. And we have a lot of work to do. So what do we mean by grassroots advocacy? By grassroots advocacy, this is taking on issue-specific initiatives, and this is driven by our member constituency. This is driven by you, by me, by any of us in our hospitals or our healthcare facilities or our freestanding facilities or wherever we are. And what we do is we work, to be representing all of us as a united community. And we want to deal with many issues, both on local and national levels. So it offers a powerful way for us to connect with those who we entrust to make decisions for us in the government. So grassroots advocacy is huge. As I mentioned, this extends well beyond Washington, D.C. It includes advocacy for our specialty at local levels, at our local medical societal levels, in our hospital, with our administrators, within our own healthcare system. And what are we advocating for? We're advocating for telling people who we are, what we do, because those are two huge areas that a lot of people don't understand, including other physicians. And probably most importantly, what is our value? What do we really bring to the table? How much money can you save the healthcare system or anybody or how much money can we save society by doing things better, cheaper, quicker, and faster, and less invasively? Because that's really what defines us as a specialty. That's who we are. And in our own practice, you can see here, we often sit around, we strategize about this. We actually have a lot of formal plans. We advocate constantly with our health system, which happens to be the largest employer in our county. We advocated our local political medical societies, and we also support the SIR initiatives that I'll talk about. So we try to do things on a national level as well. So who are the advocates? That's what I mentioned before. That's you and me. That's us in practice. It's the physician and staff leadership in the society. So it's our government affairs committee, the leaders that we have. Judy's on the phone now. She's one of our staff members who's very active in this. But I highlighted this because much of our advocacy in our society is done by residents, medical students, and fellows. And that's our SIR-RFS. And that's very commendable, and we're very proud of them for doing that. But I think that they are doing so much, and I think many of us in practice aren't doing nearly enough. This is our future. It's our income. It's our identity for who we are. It's the future of our specialty. So right now, and this webinar is actually being put on by our residents, fellows, and students section, which I, again, applaud and commend, but I would love to see more of us in practice getting involved in this. So we're the advocates, each of us, each and every one of us. So what are some of the focus areas for advocacy? Well, you may hear more about this later, but you know, as MACRA and quality payment programs have taken over, we have SIR lobbyists working with Congress and CMS to ensure SIR members' needs are addressed properly. We analyze current legal and regulatory documents, and we're really advocating is to implement plans that maximize our reimbursement and our representation. So this is one of our biggest focus areas right now. Physician reimbursement, and you'll hear more about this. This is what really I think the majority of people in practice are most worried about. This is a huge area of advocacy, and I'll talk to you a little bit about things we've done in the past in a few seconds to give you some insight into this. But obviously, we're under constant external pressures for reimbursement cuts. Many people don't realize how much we actually save by doing things less invasively. And so one of the biggest areas of advocacy within our society has to do with advocating with CMS and with our congressional leaders to work on things like our reimbursement, and when it was applicable, the sustainable growth rate, when that was still in place. So this is a huge area. And that kind of brings us to CERPAC, because those are some areas that we work in, but how do we do all this when we say we're advocating and we have people and lobbyists, and where does the money come from? Well, there is a political action committee in the society. It's called CERPAC, and many of you may have contributed. Many of you may not even know about it. But CERPAC is a Society of Interventional Radiology political action committee that's dedicated to supporting political candidates who may advance our policy and mission, as well as legislative initiatives. What does this do? It elevates the profile. It tells people who we are. It gets our name out among representatives in Congress and in the House, and it gives us some leverage when lobbying. How do you participate in CERPAC? These can be via individual donations. You can donate as a group. So our group tries to donate to CERPAC as a group where so our name is recognized, our group name is recognized. And the real goal is to raise voluntary contributions to support individuals running for office, primarily federal candidates. We don't use these funds to gain access or influence legislation. but rather just to support candidates. These funds through CERPAC aren't for grassroots activities. They're for really our national level political action. So again, what is CERPAC? It's our political action committee. What is a political action committee, if you don't know? That's an organization whose purpose is to raise and distribute campaign funds to candidates, as I mentioned before. PACs can be formed by corporations, by labor unions, by trade associations, or by any other organization to voluntarily channel money for candidates, primarily in the House and in the Senate. We can spend money on what we term independent expenditures, which are expressly for advocating the election or defeat of certain identified candidates. So we are, with our PAC, with our CERPAC, we are subject to very strict regulations. So the money is very tightly monitored and regulated. What is considered a PAC solicitation? Straightforward request for contributions to CERPAC. We try to publicize CERPAC's rights to accept unsolicited contribution. We have certain guidelines, which is what this slide's really all about. We can't just go out and make promises and ask for money, so we follow a very rigid set of guidelines. What is not a political action committee solicitation? Communications that announce the existence of CERPAC and explaining the laws applying to a political action committee, providing statistical information about CERPAC and listing candidates supported without suggesting that our political action committee will help those officials, and communications that don't encourage CERPAC support or explain how to make a contribution. Those are technically not solicitations. So there's a lot to cover here. The purpose of the webinar tonight isn't to focus just on CERPAC, but I tell you that all this information is highly regulated. We have experts within our society, and you can find most of this information on at sirweb.org. You can look this up and you can get this information. So members who are interested in soliciting voluntary contributions must complete acknowledgement forms. Again, you can get all this on the website. And I mentioned Judy is actually on this call, and maybe later, if there are any writing questions, she can address them directly. So what else do we do? Well, we have a government affairs committee. The society works on health care policy and government relations, as I mentioned. We have executive committee members and volunteers working on this. And again, you can read more about this on the website, but the government affairs section on the website can guide you through our advocacy efforts. So what have we done in the past, just to give you an idea? Well, going back almost a decade, we started looking at the SGR reform. We've looked at things like radiation safety, physician reimbursement, physician self-referral. We've increased awareness of IR, which has been a very important thing to do. And I've been part of these meetings where we're in Washington. We bring congressmen in. They've never heard of interventional radiology. They have no earthly clue. These are extremely valuable events. I've been to dinners with people in Washington who are House members and Senate members that are absolutely clueless that the stents that they have in their own heart were designed, created, invented by interventional radiologists, that we do this type of work, all the cancer work we do. So they're very happy to hear this type of thing. When there have been drug shortages, when these first started to emerge in 2012, we were right in front of Congress in the House Energy and Commerce committees. In 2015, again, we helped to try to influence legislation to require more GME funding for residency slots. We continued to push issues related to quality for value-based care. In 2016, we really pushed on focusing on regulatory advocacy, that established new macro MIPS and QPP programs. So all these are things that we've been doing in the past. And I can tell you very honestly that if you went back and looked at a lot of the cuts, and I can speak to PAD in particular, when major cuts came, one of the reasons the cuts weren't much worse, we took some major cuts 5 years ago, 7 years ago, had to do with the direct work of some of our members like Kathy Kroll working in advocacy to prevent even greater cuts. And when we worked with surgical societies and cardiology societies, but we in SIR spearheaded that. They worked with us. We weren't grabbing on and going with anyone else's coattails. We were the leaders in this. And we really impacted, I think, huge issues in reimbursement. So we have a strong history here and a lot to be proud of. What's going on right now? I think you're going to hear more about this, but you know that there are changes going on in Congress that are going to propose significant cuts to IR, and this is something we want to be on top of. Again, I think Matt may cover some of this, but SIR has taken stances on disagreeing with CMS for certain regulations and recommendations that may impact our reimbursement. And our coding and reimbursement subcommittee is prepared to strongly contest a number of issues that are coming up right now with some of the payment provisions that have been proposed. I just list some of this here that have to do with cuts that may affect any surgical or procedural specialty. IR could see a combined 8% payment reduction if all of this goes through. So we have a lot to do, and you as individuals have a lot to support. There's a lot of other examples of advocacy. I'm going to kind of push through this because there's a lot of other things, but I show this slide listing many specialties. This is what's on the table in 2020. And if you look at the bottom, you see IR -6, could be as high as 6 or 8% cuts that we're looking at. Matt will deal with a lot of this in his talk, but this is why advocacy and our CERPAC are so important to us. So looking at some of the things we're currently working on, we've worked to eliminate the 2.3% tax on medical devices. We are an innovative society. We are innovators, inventors. Having taxes on medical devices certainly limits us. We've had a number of congressional briefings to promote the benefits of IR, including briefings that featured certain congressmen who have needed IR services. We've supported one of our own IRs in his bid for Congress. Unsuccessful, but we did support him. And we're supporting all types of legislation that will help us with macro, with QPP, with billing issues, and with issues that will affect our bottom line. So we've had some live streamed briefings with Capitol Hill to bring the story of IR before people. This has been really important. As I mentioned before, in my own experience, there are lots of people who don't know about us, and once they hear about us, they get kind of fired up and they want to help us. So, kind of in summary, we have a lot of great ideas, but how do we finance them? Where are we going to get the money to do things? How are we going to get reimbursed? Well, we all need to get involved, and here's some of the things you can do to take action. You can get involved, support CERPAC. You can attend your local government. You can work locally with your group, meet with your district officials, connect with your legislators, take a voice, have a voice, stand up. And the louder we are, the more we're going to be heard. I think there's a lot that we all can do. We shouldn't leave this to our residents, fellows, and students to be our primary advocates for our society. It should be each of us in practice. So I think with that, I'm going to stop and turn this over to Matt, who will drill down on a lot of specifics for you. Thank you very much.
Thank you so much, Dr. Benenati. This was exceptionally inspiring and informative, especially for the new members of the SIR community, for our trainees, for students and residents. Advocacy is an important segment necessary for success of our specialty. And we're really proud and happy that people like you, so inspiring leaders, support advocacy and our efforts to support it as well. So we will keep all the questions till the end of the webinar, but I'm happy right now to present Dr. Hawkins, who will be discussing health policy in action, development of current procedural terminology codes, Medicare relative value scale update, and medical device creation and artificial technology.
All right, thank you, Alex. And are you able to see my screen okay, so I can get going here? All right, perfect.
Yes, we see.
Well, I think Dr. Benenati's talk is a perfect lead into mine, and sort of what I've been charged with is, or at least hope to convey to you all tonight, is all of the different steps and all of the different places where advocacy, particularly on the reimbursement cycle and coding side, can take place. So there's so many places beyond just going to Capitol Hill where things are, our advocacy is needed, and also so many places where honestly our business model is under threat sometimes for reasons that sometimes can be very confusing. So the question is how we got to this place. So for those who are new to the field, you don't know these days, but historically, when the resource-based relative value scale came out, IR was incredibly highly paid specialty. Radiology groups with IRs often relied on interventional radiology to be the profit margin. And despite the field growing into its own separate subspecialty, or a separate specialty now with its own residency and an increasing popularity and more demand from our referring physicians, it's becoming harder and harder to run an interventional radiology practice because of the number of places where physician reimbursement and site of service regulations impact us. And so hopefully today, it's not to be a morbid story by any means, because we have a lot of good things happening for our specialty, but more just to introduce this audience to the number of different places where you can have an impact in your career from an advocacy standpoint. So how did we get here? And normally, if we were in an in-person lecture, I would ask if anybody knew who this was, but I don't think it would be fair. This is a picture of Bill Shao. Bill Shao is the inventor of the RB-RVS, which is the resource-based relative value scale, otherwise known as the RVU scale, which of course, for better or worse, has completely taken over how many physicians are judged on performance. When he and his team invented this at Harvard, the intent was really just to design a tool that could measure the value of work that was being done. It was never meant to be the value or how we valued payment to physicians or physician reimbursement or physician performance, and he would tell you that. But the reason I bring that up is the very first paper ever describing the resource-based relative value scale was written in 1988. And the point is, it's not that old. And so we're still very young in this process of CPT codes and RVUs and physician fee schedules and the like. So before and really the resource-based relative value scale didn't get implemented until 1992 with a lot of work from Jim Moorfield, who at the time was the economics chair for the American College of Radiology. So in earnest, the system that we're functioning in is barely 27 years old. So barely 27 years old. It's very, very young. And I think that's part of the reason we see such rapid change all the time. Dr. Benenati talked about cuts to PAD about 7 years ago. I've been in my role as the alternate CPT advisor for the SIR now for just 5 years. And we have darn near rewritten the entire IR code set in that time. So PAD, embolization, biliary, genitourinary codes, we're aortic endographs, we're redoing PAD again. So rapid change, I think it's due to the youth. But before this was in place, the way physicians were paid was you charged Medicare the usual, customary, and reasonable fees, which I of course say, it's usual and customary for my fees to be reasonable. You can see why this was not a sustainable system and something had to be done. So first thing I want to talk about is CPT and codes. So CPT stands for Current Procedural Terminology. These are codes that describe work that physicians do. So of course, every time we do a procedure, there's a number of codes that are tied to it. When the code set was originally written in 1992, they told us to be as granular as possible. So we had a code for ultrasound guided access into an artery. We had a code then for placing a catheter within the aorta. And then there was a code for subselection of multiple arteries. And then if you did an embolization, there was another code, and et cetera, et cetera. So lots and lots of our procedures had many, many, many codes. However, that has changed over time, and there's been an impulse from CMS to bundle these codes together, so many of our procedures now just have a single code. With that being said, you might ask, why are new codes created? And I think we would love to think that it's because we continue to have new technology that's coming out, new procedures, new capabilities, things we have to describe with new codes. And that's the case sometimes, for sure. Certainly, we've recently, with a lot of the ablation technologies, we've had to get new codes for cryoablation. We're working on coding for microwave ablation, as well as upcoming other types of technologies such as IRE. But honestly, more often than not, the reason we have to make new codes is because our existing codes hit what's called a RUC screen. So the RUC has a relativity awareness, or excuse me, it's something called the RAW, which is a work group that assesses codes that are billed. They look at a number of different things, like how often it's been reported, how many times are they different codes reported together, how expensive, how much money does CMS spend on that code, is it growing too fast, is it something that's increased in time, increased quickly over time. And so then they send these back to the societies like the SIR and say, hey, this code, it's getting reported together way too often. We need you to rewrite this and bundle these codes together with a new code. And again, this is all done from the Relativity Assessment Work Group. This was put into place here not that long ago, as you can see, and really it became a bigger deal in 2009, so just 10 years ago, when the Government Accountability Office really criticized the RUC and said that, hey, CMS just can't keep accepting the RUC recommendations greater than 95% of the time, which they were at that time. So for the SIR and our coding and reimbursement team, these RUC screens have become the major driver for a lot of the work that we do at CPT to bundle new codes or create new codes that account for what was historically a multiple code effort. And here's why this matters. First of all, here's a few of the screens that tend to hit IR. It's codes that are reported together greater than 75% of the time. Well, I started off by telling you that in 1992, when we built a very granular code set, of course, ultrasound guided arterial access is reported greater than 75% of the time with many of our procedures, because we use ultrasound to access the common femoral artery so often now in our field. Also, technical expense. Turns out that IR is very expensive, right? Not only the products that we use, but the rooms that we use and the angiography suites are very expensive. Also, rapidly growing procedures. So when a new technology becomes available, it goes from 0% utilization to very high utilization in our field so often. The atherectomy device is a nice example. Where it wasn't available, then it became available and became a nice advancement for those doing PAD. Overall, they've identified 1,300 services that have been identified by these RUC screens. They're very proud of that. But because we were doing so much revision of existing codes because of these RUC screens, there was not a single new radiology code for 3 years, 2010 to 2012, which is pretty outrageous. The RUC is very proud that they've redistributed $1.5 billion from these screens, but most importantly, these screens lead to a concern for the code family. And what do I mean by code family? This is kind of an important concept. When the RUC tells us, for example, hey, you guys, liver ablation, liver radiofrequency ablation is being reported way too much. We need you to bundle that together with imaging guidance. And then after you get that new code, then we'll figure out how we're going to value it. So let's say we rewrite a new code that bundles in imaging guidance for liver ablation. The RUC says, okay, that's great. Now we need you to survey that. And we really can't just survey that code. We need to survey the whole family of codes. So maybe rather than just redoing that liver ablation code, we need you to actually do liver cryoablation as well as RF ablation. Or better, or maybe worse, they would even say we need you to resurvey all of the ablation codes, maybe not just for the liver, but we can include bone and lung and other ablation codes that we have. And we don't know what they're going to define that family as, but once they decide something is part of a family and we have to resurvey and revalue that code, the valuation of those codes is going to go down even further. They call it the revaluation. We sarcastically call it the devaluation process. And so that tends to get us in that's another place that CMS the RUC in this case can hit us, is deciding what's in that family. The reason this is also important, I bring this up, is because when we have new codes, when we have members that want us to get new codes, oftentimes those new codes could potentially bring in another existing code that would be considered part of the family. And sometimes when there is an existing code, believe it or not, there are some that we get paid very well for and very generously for. There are cases where a new code that could help members and help their business would potentially threaten an existing code that perhaps more of our members use, and that would take a big RVU cut. So this is something that we're always thinking about. Unfortunately, there's not a textbook for it, but we have to be fairly strategic. These screens have had a big economic impact, and I did this work with Zeke Silva, who is currently sits on the RUC as the ACR representative, and Andy Rosenkrantz at NYU. We did it for diagnostic imaging just because from a methodological standpoint, it's much easier looking at coding than for interventional radiology. But we looked at what the economic impact was of these screens, and the most common screens for radiology in general was just overall high expenditure, no surprise, utilization over the threshold of 30,000 per year. Sometimes CMS just thinks things are potentially misvalued. You can see that's 14% of the time, so they get to kind of choose what they think is misvalued. And then also fastest growing service, that's one of the big ones that hits IRs. One of the other new screens, and this is where it gets a little bit scary, CMS has now allowed private citizens to write in and express concern over misvaluation of existing codes. And in fact, now you've seen private payers such as Anthem who are now submitting basically their own ideas of what is a misvalued code. They're submitting them as private citizens to CMS. And you might imagine that high cost procedures like IR are being suggested by our private payers as misvalued codes. So there's a number of ways that these screens can be hit, or we might be requested to create new codes. This is what we found from our work dating back over that time period. 46% of the and this is the diagnostic side, but goodness, you can't help but feel bad for this. 46% of them got screened versus all the remaining codes in the code book, only 22% hit a screen. And you can see the reimbursement reductions, 20.3, 65.9, 75.3% respectively in those particular settings. And every single CT, MR, brain, and spine code, when it hit a screen and had to be resurveyed, reimbursement was decreased. So devastating cuts that are a result of the screens. Even after we have a code and it goes to the RUC and we do a survey and the RUC values these codes and says, all right, you're going to get paid this many RVUs for a procedure. It then submits their recommendations to CMS. And this is the next place where our reimbursement is constantly under threat, and another place where local advocacy can make a big difference. This is from our genitourinary work when we redid the percutaneous nephrostomy codes in 2015 and 2016. The numbers in parentheses in the middle column is what the RUC actually decided was a fair reimbursement, again in a relative budget type of situation. Those recommendations went to CMS, and CMS just kind of said, nah, we don't like those, we're just going to cut them. This is without any data. This is literally arbitrary off the top. We're going to cut those 15%, and so the number of RVUs that we currently get paid is what you see then on the right-hand side. And we wrote, we can write appeal levels and appeal letters, and we're working very hard to forge relationships on the CMS side because CMS, unfortunately, is allowed to, they don't have to take recommendations. They are allowed to sort of set prices in certain instances, if you will. So another place that we get, that we can get hit. even after you've got a code and CMS values it and you're happy about it being valued, there's even another layer where our coding and reimbursement team is constantly working, trying to advocate for how we get paid. But there is a private entity called the National Correct Coding Initiative. It's a private entity out of, I believe it's Carmel, Indiana still. It was started in 1996 in response to the Government Accountability Office coming out talking about all of the Medicare fraud that was out there. So tons of fraud, tons of abuse, tons of waste. And so they hired this company to basically go through and say, they do two types of edits every couple of times a year. One is, are there codes that are being reported that there's no logical reason why they should be reported together, right? So, you know, I don't know what those two might be, but you could say maybe a prostate embolization and a breast biopsy. It'd be exceedingly unusual to do both of those on the same day on the same patient. The other thing they do is they make edits that say how many times a certain code can be reported in a single instance by a single physician. So they might say that embolization of a certain tumor can only be reported once per physician per day. Then these are published and they're adopted by CMS, and you might be doing a lot more work than what you're actually getting paid for because of an NCCI edit. Now, what's crazy about this, very, very few people have heard about the National Correct Coding Initiative, or the NCCI. This is actually from an ACR article from 2003. And I admit I did not know anything about the NCCI until I started in this role in 2014. But it's become another way that I call them backdoor coding edits. Oftentimes they'll try and inject some coding edits that make no coding sense and are completely contradictory to the language in the CPT book. But our team and the coding and reimbursement subcommittee has to keep our eye out for these things. And these are the two types of edits I just discussed: the procedure to procedure edits, when improper combinations are being reported, and then mutually exclusive edits talk about how often a certain service can be reported or a certain procedure can be reported each day. And this is one example. So this is from probably 3 years ago now. The NCCI suggested that it made no sense that the biopsy of a liver and a fluid collection drainage in a liver or an abscess drain in a liver could be reported in the same instance. They said that that is medically illogical. And of course, everybody on this call probably can come up with many scenarios where you might biopsy a liver and also place a drainage catheter. And so we were able to successfully appeal this. Of course, the zero suggests that they can't be reported together. We were able to change their coding so that we could report these procedures together. So one example of a victory. We've had others through the years, but you can start to see how silly some of these edits are. And these edits are often buried. They send spreadsheets with thousands and thousands of these edits, and we have to find the ones that pertain to IR and make sure they're appropriate. This is the whole, what I call a physician payment embryology, and gives you an idea just how many levels are involved from when a code gets created till payment actually happens. And I know a lot of people in our society, we celebrate when we get a new CPT code. We think, all right, that's great. Now we're going to start getting paid for these things. And that's great when we get a code. And then it goes to the resource-based relative value scale. Again, that's the RUC. And we get valuation on these and we're feeling good about it. And then it goes for coverage. And coverage, the first step, of course, is overcoming CMS. They might decide they want to assign a lower level RVUs to those procedures. Maybe they take the RUC recommendation, and that's great. But then ultimately, the policy on whether or not these procedures are going to be covered is made what's called a local coverage determination group, or a committee that is formed by each of the local Medicare contractors. So Medicare, the service itself, is actually contracted out locally by 12 separate carriers throughout the United States. At least last I checked, it was 12. So on the very local level, you might have a local Medicare contractor coverage network decide that, for example, cryoablation of a pulmonary cancer is not going to be covered. They might just say it's experimental. They don't appreciate the data. They don't think it's well-founded. And even though there's a Category 1 CPT code, and even though there's it's been valued by the RUC and CMS, they may not necessarily pay. The likelihood of that's even higher with your private payers. So you can imagine private payers whose coverage policies are entirely proprietary and not public, they may not necessarily pay. And that's, again, where we have to advocate so strongly at the local level with our appropriate evidence tables and appeal letters, and also just having relationships at the local level with your with these local Medicare contractors is absolutely vital. And I think one of the next big steps we can take as a society towards advocating for payment coverage. The next step, even after the payers decide they're willing to pay, that's where NCCI edits come in, and further payment policy can go ahead and decrease, again, just like I discussed, the certain codes that can be reported together and how many times those codes can be reported. And then ultimately, finally, you get to physician payment. And all of these steps impact healthcare costs. And so I hope, hopefully for folks on the line, you realize the number of places and opportunities we have as a specialty to advocate for the work that we do, not just to increase our reimbursement, but we do have to be paid fairly for the work that we do in order to run a solvent business and be able to take care of our patients as well as we possibly can. I'm not going to go into great detail about site of service, but I'm going to throw one last little wrinkle in, and more just an introductory concept for those on the phone. Everything I just said almost entirely depends on site of service. So for example, if you're in a hospital outpatient setting, the reimbursement methodology is almost entirely different from if you're in an office and ambulatory setting versus if you're taking care of inpatients. I really don't want to bog this audience down with the details, because that would take, I think, a whole week of lectures to process. But just understand that everything is then different. This is what drives certain procedures into the office-based setting versus procedures that some people try to do in the hospital outpatient setting versus the ambulatory surgical center setting. Just know that the methodology is different. And so this exact same procedure might have very different payments that would be distributed into different people's pockets based on the site of service. So another concept that can impact the reimbursement for interventional radiology procedures. So I know that was a whirlwind with reimbursement, and I want to leave, Alex asked me briefly to speak about artificial intelligence, I think more from a global perspective. I'm not going to speak about specific places where it may impact IR. That's neither here nor there, and I'm certainly not a fortune teller. But I want to talk about AI, and particularly related to finances. So we're going to stick with the reimbursement theme. But I want to talk about some of the financial dilemma of artificial intelligence, specifically where I think some of the shortcomings are going to come when it comes to meaningful implementation of artificial intelligence in both the diagnostic and interventional radiology fields, and then sort of promote for those that might be very motivated to continue working on this from a career, maybe a different way to look at artificial intelligence tools for our field. So we've already talked about this, the CPT and the resource-based relative value scale process. You guys have at least an introductory feel for how that process works, but let's really get into this for a minute. So if you look at how the RUC decides how much people are going to get paid for a certain service that we provide, it's broken down into, I think some people know this, a technical component and a professional component. The professional component is further broke down into physician work, how much physician work is involved, what's the practice expense like, and then also malpractice expense associated with that work that's being done. Well, I think first of all, we can say artificial intelligence, at least the ones that are currently being written, there's no physician work involved. They run automatically, they run in the background. Sometimes they're doing data gathering, sometimes they're doing interpretation and suggestion, but there's not physician work involved. If you look at practice expense, maybe that's a place perhaps where we could start getting payment for artificial intelligence. Well, there's two different types of practice expense, right? There's direct and indirect, and this is how we get paid. Direct are line items. These are line items that are built into a RUC database that are based on invoices and actual bills. These include things like medical equipment, supplies, clinical staff, and these are single line items that accountants can point to. Indirect expenses, unfortunately, are calculated by a remarkably complicated CMS formula that's based on prior surveys, a lot of averages of costs across the United States. And rather than being individual and line items, it's a single lump sum for different types of procedures or services that you provide. And the problem, for example, one expense that we would think would be a direct expense but is not is PACS. So it turns out PACS is actually an indirect practice expense for radiology groups. The computers that they run on are a direct practice expense, but the software is not. And if AI has that same fate, the problem with being an indirect practice expense is there's no line item for your accountants to look at and determine if there's a good return on investment for the money spent on that product. There's absolutely no way to do an individual return. Again, return on investment, which I think for those of us who've been around long enough realize how important that is for some accountants. So if we say there's really no professional component of reimbursement, what about technical component? Perhaps we can find a way to get paid for artificial intelligence algorithms and software with a technical component. And this goes to the HOPS, and the HOPS is how CMS calculates how much money is going to get paid for procedures that are done or services that are provided in the hospital outpatient setting. It uses data that's reported by hospitals from around the country. Unfortunately, the data that's reported is remarkably inaccurate. It classifies then procedures and services into what's called ambulatory payment classifications, and there's a different payment level for whatever level of APC that different services qualify for. So it's also based on the geometric mean of the reported services. So for example, if only 10% of places are using artificial intelligence and 90% of places are not, the costs at those 10% of places that are using artificial intelligence is going to be diluted out by the 90% of places that are not spending that money on artificial intelligence algorithms. The cost reporting is remarkably inaccurate. In fact, one study looked at how often radiology groups were reporting the use of contrast for contrast-enhanced CTs, body CTs. So obviously it's 100% of those CTs were given contrast, and less than 15% of those studies actually had contrast reported as part of their HOPS expense, just to show you how inaccurate the hospitals report this data. And ultimately, if the cost is not reported accurately, there's not going to be any payment for it. And hospitals currently get away with this system because they have such market dominance with private payers. They basically just ramp up the costs that they report, and that's why ChargeMaster charges are so high for many services provided in the hospital outpatient setting. So this is obviously subject to change, but currently with this methodology that's being used, you can see it's going to be hard for companies that are investing in AI algorithms to necessarily see the promised land and the billions and billions and billions of dollars that could potentially be made by creating all of these new algorithms. So the question I then pose, and the opinion that I have, is I think artificial intelligence is just going to become a cost of doing business. And as soon as it becomes just a cost of doing business and not a product that's going to have its own code, or a product that's going to be paid for by the government, by CMS, and by other health insurance companies, again, the return on investment and the promise that a lot of these small companies and venture capitalists are expecting for artificial intelligence algorithms it's going to be tempered. It's going to be tempered, and just changes the way that we need to look at artificial intelligence through maybe a different and more realistic lens. And what I think, the concept I think this brings for artificial intelligence and those who are interested in developing it for our field of IR is, rather than looking at data extraction, which so many of the algorithms currently do, they want to be able to look at a particular patient scenario and come up with a diagnosis, whether that's off of an image or off of data that's in the electronic medical record. Rather than do that, I would rather have us focus on data integration. Data integration is gathering all of the data in so many disparate locations and bringing it together in a digestible format for your interventional radiologist to be able to make decisions to take care of their patient the best way. That's where we need help. That's where we fall short. That's where mistakes are made. That's where waste is accelerated. But so many of the existing algorithms are focused on the extraction of data rather than just bringing that data together and allow our human minds with problem-solving capabilities do what's best with that available data. And so with that sort of realistic financial picture of how AI is going to ultimately be paid for universally in U.S. healthcare, not just by big systems at major medical centers, hopefully it gives people a little different idea of how they may decide to develop these algorithms. And there's plenty of opportunities for IR to improve with artificial intelligence algorithms. You think about clinical decision support, patient scheduling. Everybody here knows how complex interventional radiology scheduling is, with the number of inpatient add-ons that have to be mixed in with outpatient procedures. And then even our patient experience, even just simple wait times for how long a patient may have to wait as an outpatient prior to going back for the procedure, similar to what you see in emergency departments. Those are all artificial intelligence algorithms. They can make a huge difference on patient experience. They can make a huge difference in just the overall experience of that patient, and then ultimately surveys and things that then lead into reimbursement. These are simple algorithms that can make a big difference, so we can't forget about them as a field. And so I know AI and QI have historically kind of traveled in parallel lines, and there hasn't been a lot of crossover between them, but certainly for this group, I would encourage us to look at where those lines are going to intersect, because I think those types of artificial intelligence algorithms are potentially going to be the easiest to create, the most impactful for our patients, at least in the very short term, and also improve the way our businesses and our practices function, rather than trying to find ways to get things paid for to pay back our venture capitalists and Silicon Valley investors. So with that, I will stop, Alex, and hopefully there's a few questions that Dr. Benenati and I can answer. Thanks so much.
Thank you, Dr. Hawkins. And reimbursement and artificial intelligence are definitely very difficult topics to understand for many of the physicians, and are not directly involved in health policy or economics. And we definitely have a better understanding now, and hopefully can engage more trainees to learn and get involved in economics, health policy, and all other work related to IR practice. And we have some questions and some time right now. I can start asking the questions from the audience. So Joelle Wazen, she has a question about FFS has been progressively decreasing over the years and is expected to continue to decrease. Is establishing private IR clinics, outpatient centers, a better alternative for improved physician?
So super complicated question. Love the question. So FFS, fee for service, I presume. And yes, so the value for each service that's being provided will continue to probably decrease. I think when macro was signed here a few years back, there was hope that we would move to these, value-based advanced payment models. Fee for service would go away and die. But the implementation of macro has been so challenging, and there have been so many changes to not only that, the quality payment program, but also to Obamacare, which was the foundation of the quality payment program, that we're really looking at a future of fee-for-service models right now for the time being. The question about outpatient IR practices, I think you can run a very successful outpatient IR practice. I think we have to be careful and thoughtful as a society about how we approach outpatient work, because there certainly is not a world that we can live in where every IR decides they only want to run an outpatient practice, but also not provide inpatient services. So there are many practices that have both. There are many practices that only function out of a hospital, and there are many practices that just function out of an office-based lab. Realizing that we have to provide services for all patients, even patients that cannot pay for the services that they need, as well as patients that require inpatient care and emergent and trauma services. With all of that in mind, I do think for practices to be successful, they're going to have a diverse business model that will probably include inpatient, hospital outpatient, and office-based lab services. And I know Dr. Benenati can speak to that with experience much more than I can.
Yeah, well, I think you're absolutely right, and I think having an office and being and doing work in freestanding facilities is going to be more and more important. But remember, you know, for example, if the atherectomy code gets chopped down, a lot of people working in freestanding centers are going to lose a lot. So you hate to make career decisions based on the existence of one or two codes. For some people who do that, not everybody. So because things change all the time. But otherwise, I agree with you totally, Matt.
Thank you, Dr. Benenati and Dr. Hawkins. We have a next question from Naomi Atkins, and she's asking, is there a Hill Day for SIR? And maybe Judy can tell us more about this.
Very timely question, because next week on the 24th and 25th, we have our 2019 grassroots leaders coming to Washington. Normally we have 2 fly-ins a year, spring and fall, but this year we only have a fall fly-in. We're very excited about the group. We have almost 20 folks that competed for and were selected to be in the class, if you will, of 2019. And we have 3 congressional members as guests, 2 congressmen who sit on the House Energy and Commerce Committee, which has jurisdiction over the Department of Health and Human Services, and Senator Jackie Rosen, a Democrat from Nevada who is married to a radiologist and who certainly understands what an IR is and does. So we're going to be fanning out and visiting congressional offices, about 50 approximately offices. And so thank you for the question.
Thank you, Judy. We have one more question from Naomi Atkins. And do surgeons run into RUC screens as often, and are they getting downgraded by CMS as often?
Yeah, they have not run into as many screens, and there's a variety of reasons for that. But the most common thing is because we had so many codes, particularly imaging guidance. They're called RS&I codes, or radiology supervision and interpretation codes, that were reported with the services we provide. By definition, we use imaging guides to do the procedures that we do. And that is the #1 reason that our codes have been caught in screens. And I don't mean caught as in like it's a bad thing, like we got caught breaking the rules, but they hit a RUC screen because, you know, they're done with fluoroscopic guidance every time, or they're done with CT guidance. And surgeons they don't use imaging guidance. And so many of their procedures, they don't report the same codes together more than 50% of the time. So they absolutely have not been screened as often as IR codes have.
Thank you, Dr. Hawkins. We have one more question from Will Borer, and he's asking, how much liability do you think that companies producing AI algorithms will be required to assume if their product can be independently interpret a study or perform a function?
Yeah, we talk about this a lot. I sit on the Data Science Institute at the ACR, and I don't know the answer to that. I think that's going to be the $1 million question: is at what point do they want to become completely liable and independently diagnostic? We're not even close to the point of being able to have that conversation yet. My hunch is as soon as we start having for real conversation about that, the enthusiasm for fully diagnostic data extracting AI algorithms is going to continue to wane. Because as you've alluded to, that is a hurdle that's going to be potentially insurmountable for these companies. So I don't know the exact answer, but going to be a huge issue. We haven't even gotten close to having to face it yet, though.
Thank you. One more question from Will Borer. One of the focuses of our advocacy is reimbursement. What strategy or arguments do you present to support sustaining current reimbursement rates?
Yeah, I mean, on the CPT and RUC side, it can be very challenging. I'll be very open to this audience. There are times where it's very deflating. I think part of it, though, is to find the codes that we get paid well for, making sure we save those, mitigating some of the damage. But then I think advocacy on the local level can make such a big difference. Local level meaning, one, our local carrier determination Medicare contractor committees. If you can go to those meetings, they're open, you can attend. If you get to know people there and you can improve coverage for some of these procedures that we do, if we can improve the number of procedures that get paid for, oftentimes that's going to offset or overcome a percentage of reimbursement cut for some of the procedures that we do, if that makes sense. Also for the SIR, educating our members on how to do appropriate coding and how sites of service impacts the type of reimbursement that we get. You heard Dr. Benenati mention the atherectomy code. That's a big deal if you do that procedure in a hospital outpatient setting versus an office-based lab on how you get paid and how much you get paid. A lot of our members don't know that. So teaching our members how to run a smarter practice that still provides that, that excellent patient care. So there's many ways that we do it. There's many ways that we're trying to do it. We've got a great team, and we fight hard at every level to try and find different ways to, scratch out dollars that are trying to be taken away from us.
Thank you. We have a question from Shane Lee, and he's asking, for residents who are starting to get involved with advocacy, is there a good talking points that we can use? This is probably a question for everyone.
That might be, I actually don't know, but that may be a great project for the RFS, is to come up with talking points for young attendings and people in training, and we could work with the society to create something that people could use. I would obviously have to be updated fairly frequently because we want to stay current with what's going on. But that I'm not aware that there are any. There may be, but if there aren't, I'd be strongly supportive of trying to have them created.
Alex, if I could jump in for just a second, this is Judy again.
Yes, of course.
Because we're going to Capitol Hill next week, we have developed talking points, and the webinar that we did on the 12th of September for people who were going to Capitol Hill actually has information on the webinar, which we can certainly put a link up on the SIR website, and or we can send it to the RFS listserv. So we have talking points now, and then to Dr. Benenati's point, they do change, on a fairly regular basis. But we have 4 big issues that we're communicating on right now, and we have 1-pagers, which we're going to leave behind when we talk with the congressional members and staff, and that might be looking at that webinar, viewing it. It takes about 45 minutes. At the very end, there are definitely some advocacy talking points that would be very current, that might provide a good starting point.
Thank you. That would be very, very useful. We also started with a few of the advocacy members working on some small, like 5-slide presentation. We can incorporate this all together and make a great project for like specific talking points, which we can spread to all RFS members. That should probably work.
Sounds good.
Thank you for the question. And Adam Sucher has a question. What specialties make up CMS, and how can advocacy impact the decision making in regards to reimbursement and downgrading of codes?
Yeah, CMS, it's a combination of some people that have some medical experience. And when I say CMS, that's obviously a huge government office. So you've got tons of non-medical professionals. Many of the people who've been Secretary of Health and Human Services have primary care backgrounds. You don't have a lot of, I don't think we've ever had a radiologist or an interventional radiologist in any high-level post at CMS. So certainly there have been surgical representation. It's all over the board, but just forging relationships at CMS, regardless of specialty, Remember, their job is to decrease the cost for the government. They are looking at how can we take the money that we have, provide care for the people that we need to provide care for, and make sure that we're not wasting money or people are getting paid fraudulently. And so it's less emphasis on the specialty. There's more emphasis on forging those relationships. I think we've made great headway as a specialty, especially here recently. Obviously, much work still to be done, but I don't think specialty really. I don't think the specialty drives decisions at CMS's level. Now, with that being said, there is a huge push right now to increase the valuation of evaluation and management codes, so E&M codes, and those are 50%. That's 50% of the cost of CMS is paying people for evaluation and management codes. There is a push to increase the valuation of those codes by 15 to 20%, which means in a relative system that has going to have to be paid for, that 15 to 20% by other things, and you better believe it's going to be surgery, procedures, and imaging. And so these next couple of years is going to be a real challenge for us to kind of tread the water while valuation for evaluation and management codes goes up, because there is certainly a big push for that.
You know, I would echo that. I don't think it's there's times where we want SIR to be recognized, but I think with a lot of the billing and reimbursement, I think it isn't about one specialty. It's about a group of it's about everyone coming together, and I've seen that personally in my own experiences. One thing, the FDA for sure, and CMS also, they'll come and talk to you, like when you invite them to meetings and things, but they're not interested in what specialty you are, what group you are. They're interested in what the subject matter is and what the content is. And I fully agree with you, Matt. I think that by collaborating with other specialties, we can go a lot further and get a lot more done.
Yeah, and I'll at the CPT level and also at the RUC level, I mean, there's not any meeting that goes by where we're not sitting down with the Society for Vascular Surgery, the cardiology societies, and others working on just ideas for our next code set or revisions to existing codes. We work incredibly close with the other specialties. So perhaps some of the specialty or turf wars that you might be familiar with in a clinical setting, those go out the window when it comes to coding and reimbursement and health policy, because all the specialties they're facing the same challenges. And so we work very, very closely at those levels that I just described.
Thank you. And I think our last question is from Naomi Atkins, and she is asking, are there specific resources you all use to show the cost savings for hospitals and healthcare systems when they utilize IR?
Well, I want to hear what Matt says. This is a huge area that we struggle with, and we have tried a million different things, and we're actually, unrelated to this webinar, involved in some very active things with our hospital right now over that very thing. But I think it can be very hard. That's a great question. I'd love to hear what other people say. We try, we bring them data, but sometimes the people we're talking to are only looking at, there's hard numbers that say, this device or that procedure may cost more or less, but looking at getting someone out of the hospital a day earlier is a very hard thing. We look at that and we try to show them that, but it's a hard metric, for example, or the fact that someone doesn't have to come back, or the cost of what a complication would be if you do something less invasive. Those kind of things for us are very hard to show.
It's a super challenging thing to show, and for the person that asked the question, the SIR actually hosted a research consensus panel on this back in, I think it was maybe 2017, and there was a white paper that came from that, and I think the white paper really lays out nicely the challenge of that, because as Jim has alluded to, many times the thing that people use as a metric for costs is the reimbursement. So people actually look at what their payment was or what their billable charges were and use that as the cost of providing care. And you don't have to be a financial genius to figure out that the amount you get paid does not necessarily equate to the cost of providing that service. So in the case of getting a patient out a day earlier from the hospital, if they're using the cost of that service from a payer standpoint, the payer paid a single lump sum for the diagnosis-related group admission diagnosis for that patient. They don't, frankly, from their standpoint, they don't care, how long the patient stays in the hospital. They paid one lump sum, so to them, it doesn't make a lick of difference whether they get out a day earlier or not. From the hospital standpoint, the hospitals have not developed a sophisticated, whether it's a time-based activity costing methodology. They use very antiquated direct and indirect costing methodologies for figuring out how much things cost. So then they end up resorting to reimbursement often for determining their costs. So it's very challenging to put a hardcore number on the cost savings that seem intuitive to those of us that do it in the field. I'd say this is one of the most pressing issues, certainly for people like myself. This is something that I commit a lot of time to. This is, I think, needs to be a goal for our profession, and a goal for the SIR is for us to figure out the best way to determine real savings or real value, if you will, of the services we provide. And fortunately, we have a lot of really smart people that are working on this. And I wish I could give you a list. I wish I could give you a little one-page handout for how much money we save hospitals and organizations, but unfortunately, we and no other specialty for that matter has really reached that point yet.
And this is Mia, the Director of Health Economics and Practice Development. To second what Dr. Hawkins just said, this is a focused area for the Practice Development Committee within SIR, which is just looking at ways we can show the value of IR to hospital administrators. Now, to second Dr. Hawkins's point, it is a very complex issue because each hospital system uses a variation of billing and finance structure as well in terms of calculating their revenue and calculating their real return on investment. They also use different EHR systems that are structured in terms of differently in coding. So by looking at the EHR system, looking at their finance and budget structure, and looking at how the organization itself is set up, all of those three have to be almost unanimous across the board in order for us to logistically create a system that can communicate the same thing. Unfortunately, we don't have the capacity to go from hospital to hospital, but we could in the future look into choosing a major system, maybe like the Emory system or the Harvard system, and seeing exactly within that system, how can we manipulate their EHR to reflect certain cost, or the billing to reflect certain cost, and to actually see and audit their reimbursement. But that is a task that's very difficult to do, even within just one system, and it requires a lot of manpower, but it is something that the practice development committee is looking into. And Dr. Hawkins has actually been a huge influence in pushing this initiative, along with Ray Liu, who is part of the Mass General group, and what Massachusetts General Hospital. And what we're looking into in working with RBMA is to see how do practice administrators really view IR. Currently the rhetoric is that IR is a very small component of a larger multi-system, multi-specialty organization. But if we are to show them the value of IR, which is where the core starts, then we can get them to pay a little bit more attention to how cost allocation or even reimbursement allocation is divvied out to our specialty. But that is something SIR is working on. And as we get more detail, we'll be happy to share it with you guys. And you can stay in touch with me and Judy, and we will update you on anything else we have coming up pertaining to that.
Thank you.
All
Thank you so
right.
much. I think our meeting coming to the end, and we're already almost out of time. So I want to thank you, Dr. Benenati. I want to thank Dr. Hawkins, Judy Bukala, Mia Kurama. And this was absolutely incredible and so much needed information for all the IR members, especially those who just started getting engaged with SIR Society. And thank you everyone who joined us tonight. And if you have any additional questions or suggestions, we're happy to continue the discussion offline through RFS Advocacy, Health Policy and Economics Committee. And for those who are unable to join tonight, and I already get in some text and emails that some people wanted to join, but they, due to scheduling, could not do that. There will be available recording of this session, and it will be posted at RFS YouTube page. And we will keep everyone updated about our upcoming advocacy and health policy projects. Currently, the closest one is organized by Government Affairs, CERPAC. It will be a grassroots leadership program next week. And then we also work together with RFS Women in IR Committee. And in December, Dr. Ferrara, I've seen him on the call tonight as well, and he will be presenting also some topic on political advocacy. So thank you so much. Thank you for joining us tonight, and have a good night, everyone.